Today we have Dr. Sarah Gabriel. She's going to be speaking on postpartum obsessive compulsive disorder. She earned her medical degree from the University of Wisconsin, and she recently finished her fellowship in child and adolescent psychiatry from the University of Hawaii, John A. Burns School of Medicine. So, Dr. Gabriel?
My presentation's on postpartum obsessive compulsive disorder. I have no disclosures. And these are my learning objectives. My first objective is, sorry, let me make this smaller so I can read. Okay. Okay. First objective is to recognize negative effects of postpartum obsessive compulsive disorder on baby and mother. Describe common symptoms in postpartum obsessive compulsive disorder. Differentiate postpartum obsessive compulsive disorder from postpartum psychosis, and then identify common treatments of postpartum obsessive compulsive disorder. What I'd like also to is when I say postpartum, I am referring to the period after childbirth. And then moving forward, I will refer to obsessive compulsive disorder as OCD because the other way is much longer. Okay. I'd like to start off with a clinical vignette that illustrates the challenges of the postpartum period. So we have a patient called Miss C. She is a 29-year-old G1 P1 female. Um, G1 P1 being this is her first pregnancy and she has delivered one child. She has no prior psychiatric or chronic medical condition history, and she presented to the emergency department 4 weeks postpartum. So it's been 4 weeks since she had a baby. She's presenting with significant anxiety, and she delivered her first baby via an uncomplicated vaginal birth. And then since delivery, she has been sleeping only 1 to 2 hours per night, repeatedly checking the baby's breathing, or she is excessively cleaning breast pump supplies. She has been exclusively breast pumping because of painful lack. Miss C reports persistent, distressing, intrusive thoughts about unintentionally harming her baby. For example, she has concern of dropping baby from her stairs banister or from the diaper changing table. These thoughts occur for 5 to 6 hours daily and has led her to avoid even carrying or feeding her baby altogether because she has fear. She describes being constantly on edge and afraid she might accidentally hurt her baby and expresses intense guilt, feeling she is a bad mother. So this case sets the stage for our discussion on the topic of post OCD, and I will come back to the case later on. Okay. A bit more about the case before I come back later on. She is not on any current medications, no past medication trials, treatments, no prior history of surgeries, trauma, seizures. Her mom does have a history of anxiety, unclear the type diagnoses or if she's on medication. Socially, she married, lives with her husband of 5 years, and she's currently on maternity leave. And she has a college degree and she works as a CPA when she's not on maternity leave. Her husband is employed full time currently, and they are not on government assistance. On physical exam, some findings as she appears anxious, uncooperative to speak. Her affect and mood is congruent. She describes herself anxious. Some psychomotor agitation, as in she's like wringing her hands, kind of fidgeting, getting up to walk. She's very anxious about being at the doctor's. But otherwise, no other abnormal movements, no signs of like overt self-neglect. Okay. So let's take a quick look about the prevalence of general OCD, which contextualize postpartum presentation. 12-month prevalence of OCD among US adults is approximately 1%. But when we break it down by sex, the prevalence is notably higher in females than males. The lifetime prevalence is around 2.3%, which suggests that a portion of individuals experience OCD symptoms at some point in their life. Importantly, average age of onset for females is between 22 to 24 approximately, which directly overlaps with a lot of the reproductive years. And so this shows a very critical window of vulnerability for. And throughout this presentation, I will primarily use the terms women or female when referring to individuals affected by postpartum OCD. This reflects the terminology used in research and clinical literature, focuses on individuals with female reproductive anatomy who have given birth. However, I want to acknowledge not all individuals who experience childbirth identify as women. Okay. So in terms of postpartum OCD prevalence, it's important to note that it's vary across different studies. It's very variable, which is likely due to the differences in methodologies, diagnostics, and timing of assessment. One source for the prevalence of postpartum OCD is a large meta-analysis with data from over 8,000 females. They found a pooled postpartum OCD prevalence of about 2.43%, meaning out of 100 postpartum women, a little over two experience postpartum OCD. And then relative risk based on these studies was at 2.38, meaning in the postpartum period are more than twice as likely to develop OCD compared to the general population. This shows that there is definitely an elevated risk that supports the importance of staying of the development of this in the postpartum period. So this is a study, a prospective cohort study examining the prevalence, timing, and onset patterns of OCD symptoms in the postpartum period. The study looked at over 700 women, but about 400, a little over 400 of them completed the follow-up study postpartum. The study found a cumulative incidence of new onset OCD after birth of 9%, and that's the percentage of new cases that developed in the postpartum period. And then period prevalence, meaning those who met criteria for OCD, new and old cases. So at any point during the postpartum period was 16.9%. And so kind of looking at this graph right here, this graph shows the estimated prevalence of OCD from an approximately 10 weeks before delivery through 25 weeks postpartum. The solid line represents the average prevalence at each time point, while the shaded area around the line reflects 95% confidence interval, which just gives a sense of the statistical uncertainty from the bolded line. Now, as we can see, OCD symptoms rise shortly before delivery and peak around 6 to 8 weeks postpartum, where the estimated prevalence reaches a little less than 10% prevalence. Throughout the curve, you do see a gradual decline after the peak, but the prevalence does remain elevated through the 6 month postpartum period. And this path suggests that the period is definitely a particular vulnerable time for the onset or even exacerbation of OCD symptoms, and could be an optimal window for screening people, individuals postpartum. Now, this is another graph from the same study, the cumulative incidence of OCD. So again, it's the number of new cases accumulated over time. We start at 0 right after birth and track new diagnoses week by week. As the time goes on, the line goes up, which means that more people are developing OCD symptoms. And most of the increase happens within the first 6 weeks after birth. And by about 20 weeks, the line goes off a little, 0.1, meaning that about 10% prevalence or nearly 1/10 experience new onset of OCD postpartum. And this just goes to show again, reiterating that postpartum OCD is not rare, and most cases can emerge within the first few months after birth. And so, just for nomenclature purposes, when postpartum OCD is discussed, like I said earlier, it refers to the onset or exacerbation of OCD symptoms at delivery. Diagnostically, postpartum OCD is classified as OCD, and diagnosed the standard criteria for OCD as depicted in that blue book on the screen, the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition text versions. There is no specific specifier available for OCD in the or perinatal period, and overall OCD is not seen as clinically distinct, but it does have symptom themes that are uniquely tied to the postpartum experience and also important to identify for treatment. And disorders that do have some peripartum onset specifiers. Peripartum is the onset of a disorder during pregnancy or then 4 weeks postpartum. Some of them disorders that have the peripartum specifier include depressive disorder, bipolar disorder, brief psychotic disorder. Overall, I have here the OCD diagnostic criteria, which is the postpartum OCD, and includes the presence of obsessions, compulsions, or both. Obsessions, simple unwanted intrusive thoughts or urges or images that cause significant distress in an individual. The individual tries to support and neutralize these thoughts, and often with a compulsion. Compulsions are repetitive behaviors like hand washing, checking, or mental acts. These are performed to reduce anxiety or prevent a fear event, and even if they're not logically connected to the threat itself. And the obsessions or compulsions must be time consuming or cause clinically significant distress or impairment in social, occupational, or other important areas of function. The symptoms can be attributable to the physiological effects of a substance or another medical condition. And finally, the disturbance is better explained by the symptoms of another mental disorder. Now that we've reviewed core diagnostic criteria of OCD, it's important to recognize how obsessions and compulsions can manifest in the postpartum period because it can be underdiagnosed or misdiagnosed. So while the underlying mechanism of OCD remains consistent, the content of obsession and postpartum OCD often shifts to focus intently on the baby. This makes sense given the major life transitions to parenthood, heightened responsibility, and the emotional vulnerability during this time period. Some of the most common obsessive themes include obsessions of the baby dying unexpectedly, such as during sleep or due to perceived neglect or oversight. Fear of harming the baby, either intentionally or accidentally. These may involve intrusive thoughts of dripping, shaking, or suffocating, or stabbing the baby. That picture on the left there, in the past, many parents used traditional cloth diapers secured with a metal diaper pin or even clothespin. And these diapers were made from folded cotton and to be fastened manually, which requires a lot of care and precision. Understandably, this can create safety concern. If not secured properly, these sharp pins could accidentally poke or scratch the baby's delicate skin, and this can be definitely seen as an obsessive thought. But fast forward today, the diapering has come a long way, and there are plastic safety or snap closures for cloth diapers. So eliminating that need for pins entirely or concern of like stabbing baby pin. Next, there is contamination fears, such as worry about exposing the baby to germs, bodily fluids, or chemicals. Intrusive thoughts about being exposed to harmful substances, unsafe environments, toxins, radiation, household products, and crime where you live. Fear of making a fatal mistake, for example, giving medication to baby, forgetting to check on the baby, or making a poor decision. One theme that's very difficult for parents to bring up is sexual intrusive thoughts involving the baby and graphic visual images of the baby being injured, mutilated, or dead. In addition to these core themes, less common but still documented obsessions I've read include intrusive thoughts about putting the baby in the microwave, throwing the baby from a balcony, or accidentally running them over with a car. I'd like to point out that these obsessions, they do not reflect a desire or act on these thoughts, but rather highlight the intense anxiety and just the hyper responsibilities many parents experience postpartum. And then when we think about the OCD compulsions, we often picture, hand washing, checking locks, arranging items symmetrically. But in postpartum OCD, while the compulsions still serve to neutralize the intrusive thoughts and reduce anxiety, their content and context are uniquely tied to the infant and the maternal role. First, we can see a lot of checking behavior. But instead of checking doors or stoves, mothers can repeatedly check whether their baby is breathing, safely swaddled, or properly fed. Next could be cleaning and decontaminating. That's very common with focus on feeding equipment. There's a picture there of breast pumping gear. That's a Spectra brand. And all of those bottles and things need to be washed a lot if you're pumping breast milk a lot. Next is avoidance behaviors, especially can be prominent. Mothers may avoid being alone with baby, using stairs or handling sharp objects for fear of harming the baby. And then there's a lot of reassurance seeking, frequently involving like family members or clinicians to confirm that the baby is safe or that they are not a danger to their child. Many women may also restrict physical contact with baby, like avoiding holding, feeding, or bathing it out of fear that they'll act on these intrusive thoughts. What's less often recognized are the internal compulsions. Mothers may engage in mental rituals, such as silently praying or repeated phrases to neutralize these thoughts, or mentally reviewing their actions for signs of that they may have caused harm. Finally, we often see compulsive safety behaviors like hiding knives, locking up sharps, avoiding media that could trigger violent or intrusive thoughts. So while the form of compulsions may resemble those seen in general OCD, their content is deeply specific to maternal caregiving, making the postpartum OCD uniquely impairing and often misdiagnosed. Screening tools that can be helpful for identifying postpartum or perinatal OCD and related psychiatric conditions are here. Um, while structured tools can guide our assessments, they should not they should always be used alongside a thorough clinical interview uh, to help assess all mental health symptoms and history. For OCD, several validated tools are available to assess postpartum specific OCD symptoms, although they're not diagnostic. There's the Obsessive Compulsive Inventory, a widely used self-report measure. There's a Perinatal Obsessive Compulsive Scale, which includes both prenatal and postnatal versions. It's a screener slash severity tracker. There's a 10-item postpartum distress measure and the parental thoughts and behavior checklist. Both screen intrusive thoughts and parenting related compulsions. Of note, not a screener, but gold standard for OCD is the Yale-Brown Obsessive Compulsive Scale, uh, severity scale. It's used once OCD is suspected or diagnosed, and it's used frequently in OCD research to track the severity of symptoms. And for other psychiatric comorbidities, they're on the right. They can often screen for depression and anxiety. It's the Edinburgh Postnatal Depression Scale, well established for postpartum depression. You can use the GAD-7 and the Perinatal Anxiety Screening Scale to help capture co-occurring anxiety symptoms, which are very common to co-occur with postpartum OCD. But ultimately, no screening tool can replace clinical judgment. A comprehensive clinical interview is essential to assess severity, context, and functional impairment, especially when evaluating risk and distinguishing between OCD, depression, or even psychosis. Next, I will talk about just the course of general OCD for context. Symptoms typically begin gradually rather than suddenly. Their slow onset can make early identification of general OCD challenging. OCD tends to follow a chronic waxing and waning pattern, meaning symptoms may fluctuate over time, but often persist without full resolution. Symptoms often worsen during periods of stress in life, transitions, or notably the perinatal period, making this especially relevant in postpartum cases. Some individuals may experience partial remission, where some symptoms may lessen but not fully resolve, while rather than spontaneous remission. As for prognosis, outcomes are better when OCD is identified early and treated effectively, and when the individual has good insight and fewer psychiatric comorbidities. For the course of postpartum OCD, there is not a lot of longitudinal literature as for general OCD. But from what's available, it's seen about half of affected women experience sudden symptom onset, while the other half have a more gradual progression. The condition often follows a chronic course, and the symptoms can worsen during the perinatal period, especially in women with pre-existing OCD or comorbid conditions like depression or anxiety. The trajectory of OCD can vary greatly among individuals and can be influenced by many factors, such as the comorbidities like anxiety, depression, making the OCD more persistent, even harder to manage. In some cases, the course may be episodic, with symptom flares triggered by hormonal changes or stressors, especially think sleep deprivation. These patterns can delay recognition if they're mistaken for just typical postpartum adjustment. This is a retrospective chart review of 132 women with established OCD diagnoses. The study goal was to assess changes in OCD symptoms during the postpartum period. And after giving birth, about 29.2% of women experience a worsening or exacerbation of their pre-existing OCD symptoms in the postpartum period. Interestingly, a small percentage, about 8.3%, actually reported symptom improvement. And the majority, about 62.5%, had no changes in their OCD symptoms and severity. These findings overall suggest that exacerbation is quite common. 30% is quite a bit. That's about 1 in 3 women have their OCD exacerbation in the postpartum limited period. I'd like to point out that experience obsessive compulsive symptoms in the postpartum period does not necessarily mean a person has postpartum OCD. So I have that equal does not equal sign. Intrusive thoughts, especially of infant harm, are very common in new parents. One cross-sectional study I found showed up to 50% of mothers report at some point having these symptoms. In the International OCD Foundation website, they cite about 80% of new parents experience distressing, intrusive thoughts of infant harm. Most parents who experience these thoughts do not meet diagnostic criteria of OCD. Next, I will talk about just negative effects of postpartum OCD. There was a comparative cross-sectional study involving 37 postpartum mothers with OCD versus matched control groups without OCD. The study looked into how postpartum obsessive compulsive disorder affects parenting experience and mother-infant interactions. Some key findings include mothers with postpartum OCD reported significantly greater parental stress, parenting stress, lower confidence, and higher self-criticism. During observed interactions of mother and infant, mothers showed reduced sensitive responsiveness and were less likely to engage in positive emotional exchanges with their infant. And comorbid depression with the postpartum OCD further exacerbated parenting difficulties. Notably, this study found no evidence of actual harm to infants, though mothers exhibited the hypervigilance, excessive caution, and avoidance behaviors. This slide just depicts the wide-ranging negative effects of untreated postpartum OCD. Parents may experience intense distress driven by the intrusive thoughts and compulsions. These symptoms can be impairing to daily functioning, with some finding it difficult to just complete routine tasks, just like feeding or holding the baby. Sleeping is often disrupted by the obsessive checking, cleaning rituals, and avoidance behaviors, which may lead parents to just emotionally distance themselves from the baby. As a result, parents' confidence can erode. Many parents worry that they are dangerous or incapable and without intervention. Postpartum OCD may become chronic, increasing just the long-term psychiatric burden. And lastly, the entire family system may be impacted. Strained relationships, increased caregiver burden, disrupted routines can lead to broader family stress. So overall, the takeaway from these negative effects is just like early recognition and treatment of the postpartum OCD is essential to safeguard the health of both parent, child, and family. Postpartum OCD is frequently accompanied by other psychiatric conditions which can complicate diagnosis, prognosis, and treatment. Most notably, comorbid depression is highly prevalent, with rates ranging from 43 to over 70%. So it's just really underscores the need to screen for mood symptoms during assessment. Comorbid anxiety disorder also very common, and 27.5% of individuals with postpartum OCD may have amplified obsessions and compulsions. And then additionally, about 18.4% of women with postpartum OCD may meet criteria for PTSD, postpartum traumatic stress disorder, often linked to traumatic birth experience or even prior trauma. These comorbidities can worsen just the functional outcomes as well as delay treatment engagement, highlighting, really important for the comprehensive perinatal mental health evaluation. This is kind of a busy table, but it just really helps differentiate postpartum OCD from the other perinatal psychiatric conditions that can appear similar. There's the baby blues. It's a mild mood change that are usually self-resolving, requiring no treatment. There's the depressive disorders and generalized anxiety disorders, which may begin antepartum or postpartum with symptoms like sadness, anxiety, or worry. And there is postpartum psychosis, which has egocentric thoughts. Egocentric thoughts are unwanted thoughts that align with one's values. They think they need to do this. It requires immediate hospitalization and medication treatment. OCD stands out from these syntonic thoughts because it's ego dystonic. These are unwanted thoughts that go against somebody's values. I want to discuss next postpartum psychosis as it can overlap with postpartum OCD symptoms, such as because both of them can involve disturbing thoughts about the baby. But postpartum psychosis should be considered. It is a psychiatric emergency that needs immediate treatment because it has a high risk. On average, about suicide is about 5% in the mothers, and infanticide from postpartum psychosis about 4%. Clinically, postpartum psychosis is characterized by mood instability, delusions, hallucinations, agitations, and disorganized behavior. Having a history of bipolar disorder is a risk factor for developing postpartum psychosis. And so this is just side by side to differentiate postpartum OCD from postpartum psychosis. Again, postpartum OCD is common, typically presenting with ego dystonic intrusive thoughts that are unwanted, distressing, and inconsistent with a mother's value. The hallmark feature is that these thoughts cause significant anxiety, often centered around unintentional harm to the baby and then fears of harming baby. Mothers with postpartum OCD are usually highly distressed from these thoughts. In contrast, postpartum psychosis is rare. About 0.1 to 0.2% of births this can occur, but is a psychiatric emergency. It has the egocentric thoughts, meaning that the mother does not recognize these thoughts as problematic and include, again, the delusions, hallucinations, and disorganized thoughts. So when it comes to treating postpartum OCD, we should treat if the symptoms are distressing and interfering with a patient's functioning, whether that's in caregiving, bonding, sleep, or safety. It's important to note that there are currently no formal disorder-specific treatment guidelines for postpartum OCD. As a result, treatment is modeled after general OCD treatment with modifications to fit the postpartum context. Common mainstay treatments include cognitive behavioral therapy, with particular emphasis on exposure and response prevention. This is the first line psychotherapy. In moderate to severe cases, we can also consider medications, most often antidepressants, such as the selective serotonin reuptake inhibitors. Finally, there you can do a combination of treatments, both cognitive behavioral therapy with exposure and response prevention and medications. But ultimately, medication should really be personalized. Treatment should be personalized to the patient. For context, just on general OCD treatments, Here it depicts a systematic review and network and meta-analysis of randomized controlled trials involving over 6,000 adults with OCD. One subsection of the study compared the efficacy and acceptability of the different treatments of OCD. So this graph on the right here depicts the combined probability of full and partial treatment response across different OCD interventions. Starting from the left three bars, we have pharmacologic interventions, different medications. They are antidepressant medications, the SSRIs, venlafaxine, it's a selective serotonin and norepinephrine reuptake inhibitor, less established than the SSRIs, uh, or clomipramine for OCD treatment. That's another antidepressant, but an older medication. It's a tricyclic antidepressant that is used to treat OCD and is relatively selective for the serotonin. The antidepressants here show a modest response rate, about 50 to 60%. Then the three bars to the right of those initial three bars are psychological interventions. So they have behavioral therapy, cognitive therapy, and cognitive behavioral therapy. Um, so the behavioral therapy is specifically exposure and response prevention. It had the highest overall response rate of nearly 93% of participants achieving clinical improvement. Notably, the majority of this was full response and indicated by the blue portion of the bar. Cognitive therapy, which focuses on modifying maladaptive beliefs, also showed strong effectiveness, about 90% overall response. Again, the majority were full responders. And in comparison, the CBT, cognitive behavioral therapy, which is a combination of cognitive and behavioral techniques, it showed a somewhat lower overall response rate, about 63%, but the authors suggested that this difference was due to methodology and studies of design differences, which may have affected CBT's performance. But regardless, the takeaway is that behavioral therapy and cognitive therapy are highly effective first-line treatments. Um, for there are relatively few studies that directly evaluate treatment of postpartum OCD. Much of what we know about treatment is extrapolated from broader OCD and anxiety literature. But shown here is a systematic review that examines studies on postpartum anxiety disorders, including OCD, with the goal of evaluating current studies regarding the diagnosis, course, and treatment of anxiety disorders during pregnancy and the postpartum period. In the postpartum OCD group, studies were sparse. Um, let's see, with a focus, there's like about 9 studies mainly consisted of just like case reports and case studies with very small sample sizes, unfortunately. And for the same systematic review results from the study, collectively, they support the efficacy of both SSRI and CBT with exposure and response prevention for treating postpartum OCD. And they showed positive maternal outcomes and minimal infant risks reported from these studies. But again, very low population size and not randomized control trials. So this is an algorithm that outlines a stepwise approach to treating OCD in the perinatal period. And the most common evidence-based treatments for postpartum OCD, including SSRIs, antidepressants, and CBT with ERP, exposure response prevention, either alone or in combination with an antidepressant, titrated to the maximum tolerable dose. If there's no adequate response after 12 to 16 weeks, the cognitive behavioral sessions or 4 to 6 weeks of medications, the treatment plan should be escalated to other treatment options. Options can include switching to another medication, such as a different type of antidepressant, or switch to a different class, or augmenting with another medication, such as an atypical antipsychotic. Also to point out, there are perinatal specific considerations in late pregnancy. Later pregnancy, due to the fluid differences in a woman's body, you may need to reduce it can reduce the antidepressant plasma levels by about 50%. So dose adjustments may be needed in the resulting postpartum period. To summarize the gold standard therapy for OCD, it's the cognitive behavioral therapy with exposure and response prevention. It basically combines cognitive therapy and behavioral techniques. You have the exposure portion, which involves gradually the patient confronting the thoughts, images, or situations that trigger the anxiety. And the response prevention means you will resist the urge to perform the compulsions in response to that anxiety. Together, these strategies help patients break the cycle of the obsessions and compulsions, and over time, this may reduce distress and improve function. You may need to do imaginable exposure, which is not in-person exposure, just the patient thinks about it, because a lot of the subject matter or the intrusive thoughts in these postpartum patients may be really distressing themes because it could be harming baby. Um, In terms of medication, the first line therapy is the antidepressant class called selective serotonin reuptake inhibitor. If the initial SSRI is ineffective, second line options can include switching to a different SSRI or trying clomipramine or venlafaxine. Mirtazapine is another alternative antidepressant with emerging evidence. And for partial or inadequate response augmentation, that's adding on a different medication to your antidepressants, such as an antipsychotic medication, such as aripiprazole, risperidone, olanzapine, quetiapine may be considered. But ultimately, these strategies really should be tailored to the patient's preference, their symptom severity, and the safety in the postpartum context. One thing I'd like to point out when working with this population is when treating postpartum OCD with medications, it's important to consider medications that have previously been effective in the past for the individual. Because if a patient has responded well to a specific antidepressant or medication trial in the past, the agent is often a reasonable first choice, provided it is compatible with the perinatal safety considerations. This helps just reduce trial and error and potentially shorten the symptom relief. And this slide just shows findings from a randomized controlled trial of 100 adults with general OCD who had inadequate response to their antidepressant, their SSRI. Patients were randomized to either receive exposure and response prevention, risperidone, or placebo. In response, uh, oh, in the graph on the right, the exposure response prevention led to significant reductions in the YBOS scores over 8 weeks. This is the scores. The lower score, that means the better your OCD is getting. This really shows a strong clinical improvement. In contrast, the medications, risperidone showed no significant benefit over placebo, so no treatment at all. This overall suggests that behavioral therapy, more specifically the exposure response prevention, is more effective than antipsychotic augmentation or adding that onto an antidepressant for antidepressant resistant OCD. In terms of medication and lactation, so breastfeeding or just feeding women's breast milk, antidepressants as a class are generally considered reasonable to take while breastfeeding. Of the antidepressants, sertraline and paroxetine have the most data supporting their use in breastfeeding mothers. More about lactation and medications. Most medications prescribed for OCD are secreted into the breast milk, but the concentrations can vary significantly. Exposure factors can include the dose of the medication, mother's metabolism of the meds, the frequency that they feed the baby, and the timing of feeds relative to when the medication was administered. To assess the infant's exposure to the medication that a mother is taking, if they are giving the baby breast milk, we often refer to a term called the relative infant dose, or RID, which compares the dose the infant receives via breast milk to the maternal dose that the mother takes of their medication. And the American Academy of Pediatrics recommends an RID of less than 10% as being acceptable and relatively safe for a person to take while breastfeeding or giving breast milk. Finally, I wanted to also say that give caution to sedating medications, which may lead to infant lethargy, feeding difficulties, or a mother just being too tired. There are multiple sources out there to assess medication and lactation. One key resource is a website called LactMed. It's a database provided by the National Library of Medicine. It offers evidence-based information on drugs that breastfeeding women may be exposed to. LactMed includes data on drug levels in both maternal blood and breast milk, as well as any known effects on breastfed babies and on lactation itself. It also provides recommended alternative medications when appropriate, along with scientific references to support clinical decision making. On the right-hand side there is a screenshot of the LactMed results for the antidepressant sertraline. Sertraline's relative infant dose is typically below 2%, well under the commonly accepted threshold of 10%, which suggests it's a low level of drug transfer into a mother's breast milk and can be considered a reasonable first choice for postpartum OCD. So when managing postpartum OCD treatment, treatment planning should be comprehensive and patient-centered with a lot of key clinical considerations that I have depicted here. There should be a risk assessment, weighing the risk of untreated OCD, such as impaired functioning, parent-infant bonding, against the potential risk of treatment, including medication exposure during lactation. There's the severity of illness. Assess how significantly the OCD symptoms are interfering with a mother's daily life and safety. The severity will help determine just the urgency and intensity of treatment. Next is diagnostic clarity. You should really ensure that the diagnosis is accurate, differentiate OCD from postpartum depression or psychosis, as each requires their own very distinct treatment approaches. Of course, look at the past psychiatric medical history to assess other, psychiatric treatments or co-occurring medical conditions. Past responses to medications can help guide future treatment choices. Family history considerations, if there's a family history of OCD or even perinatal history, this can show the risk of treatment response. There's a lot of patient-centered factors, incorporating patient's preference, breastfeeding goals, social support. A lot of shared decision making is essential during the postpartum period. When I've seen postpartum patients, especially mothers, it's good to get other family members involved, like partners, like husbands, or their grandmothers, to see, am I going to be sedated for medication? Can someone watch the baby while I'm getting treatment or attending appointments? There's long-term planning. Treatment decisions really should account for future reproductive goals and maintenance of mental health stability over time. And next is relapse prevention, developing a plan for just sustained support and monitoring, as postpartum OCD can recur in subsequent pregnancies or even under stress. Now, to return to the case of Miss C that I was talking about earlier, she had, so or to summarize Miss C, she had intrusive, unwanted thoughts of harm, specifically about dropping her baby. These thoughts are ego dystonic, so go against her values. Were highly distressing, occurring for several hours a day, leading to a lot of compulsive behaviors like checking and avoidance, not wanting to hold her baby. Despite severe sleep disruptions and caregiving avoidance, her insight did remain intact, and there's no history of psychosis. These symptoms of Miss C really aligns closely with the diagnosis of postpartum OCD. Treatment considerations for her, depending, on the treatment considerations, could be the exposure response prevention, and/or trialing an antidepressant. This table just compares the possible postpartum diagnosis to postpartum OCD for Miss C. Postpartum OCD, again, has an ego dystonic intrusive thoughts, preserved insight, sleep loss due to compulsions, anxiety driven avoidance. In contrast, the postpartum psychosis would have bizarre delusional thoughts, poor insight, disorganized behavior. It requires urgent hospitalization and treatment. Postpartum depression may include passive or absent thoughts of harm, um, but also with preserved insight. It is more characterized by low energy, detachment, and not the compulsive behaviors. I want to further emphasize that this differentiation is important for selecting the right treatment and ensuring mother and baby's safety. Um, So back to Missy again, she went to the emergency department. So here I wanted to compare some evaluation strategies depending on the different clinical settings as it can significantly shape approach to care. The emergency room, the primary goal is to rule out psychiatric emergencies, particularly the postpartum psychosis. The initial evaluation is focused on rapid, focused assessment of safety to determine whether the mother retains insight or is experiencing psychosis. The key concern here is ensuring safety of both mother and baby. In terms of differentiating of the OCD, it's more likely when the mother shows preserved insight and distress over thoughts. If instead she presents with delusions or lack of insight, psychosis is more likely. And then if the patient is stable with no active risk, her insight is intact, she can typically be discharged with a referral to outpatient care to see a therapist, a specialist, and then psychiatry or even her PCP to get a referral. Other interventions in the emergency department can include education on the condition, ensuring immediate safety, and arranging urgent referrals. The referral plan is connecting her with perinatal mental health specialists within a few days, so trying to be really close to follow up. In contrast, in the outpatient setting, it's really to offer the opportunity to diagnose and manage OCD over time. The initial evaluation involves a detailed clinical history and utilizing validated screening tools to help assess OCD symptoms. The main concern shifts to assessing functional impairment, symptom duration, comorbidities, and the level of insight. The differentiation between OCD and psychosis in the outpatient setting involves confirming the presence of the obsessions and compulsions and avoidance behaviors over multiple visits. For disposition in the outpatient setting, we focus on creating a personalized treatment plan and establishing regular follow-ups. Key interventions include, doing the CBT with exposure and response prevention, considering an antidepressant, and providing ongoing education and emotional support. Um, hmm. And I'd like to point out, many parents with postpartum OCD may be afraid to speak up. They worry that disclosing intrusive thoughts, often about accidentally harming their baby, will lead to judgment, misunderstanding, or even child protective service involvement. These obsessions and compulsions go against the parents' values and intentions. They are common in the postpartum OCD period and not necessarily a sign of danger. They're just symptoms of a treatable condition. I want to discuss briefly ways to elicit and support disclosure of postpartum OCD symptoms if you are working with a parent that is postpartum. And I'd like to preface this by saying there are many ways of going through this, but one such way that I've utilized is by starting to normalize the experience. You can say something like, it's common for new parents to have unwanted or scary thoughts. You're not alone. Then we gently elicit symptoms using open-ended or specific questions. For example, have you had thoughts that felt upsetting, or out of character? Or some people have thoughts like dropping the baby. It's essential to validate what parents do share with you. Saying that doesn't mean that you'll act on them. These thoughts are symptoms of the anxiety or the illness, not your intent. From there, we can shift into support communication, providing reassurance that these thoughts don't mean you're a bad parent, using clear, non-judgmental language to really normalize help-seeking behaviors. Provides, you can provide statistics like 1 in 5 women experience postpartum mental health conditions. This can help normalize things. And finally, really focusing on recovery, we want to emphasize that treatment, including therapy and medication, is effective and can improve both well-being of parent-infant bonding. There's a lot of educational material. The key is just to really meet parents with empathy and evidence, helping them feel safe, supportive, and empowered to get the care they need. I'd like to just now talk about just brief resources. Hopefully, you can have my camera on, but I'll add it later. So there is several valuable perinatal mental health resources available in Hawaii. There's the Postpartum Support International Hawaii chapter. It provides support groups, local referrals, and educational materials. They connect parents to trained volunteers. And then also professionals like can have there is a something called a perinatal psychiatric line, which a provider that has a perinatal mental health question, you can fill out a consultation form, and someone from PSI will get back in contact with you and provide support for your question. And then next, there's Healthy Mothers, Healthy Baby Coalition of Hawaii. They offer a lot of mental health counseling, screenings, referrals, and wraparound support services for perinatal mental health. They also engage in maternal and child mental health education and advocacy. One resource that I used was something called the Lactation Lounge. That's the address right there. They meet up every Tuesdays. They offer feeding support, baby wearing assistance, and just a space for other parents to hang out. I had a baby about 8 months ago, and it was very difficult, with the adjustment for me to want to leave the house. But this was a great space that I felt safe in. These are other local support resources in the community. Nurture, it's an organization with a specialized mental health clinic, with a specialized mental health clinic for postpartum, reproductive, maternal mental health support. They offer therapy and medication management. There's Family Hui Hawaii. It's a peer-led support for parents through groups, education, play-based connections. I follow these educational resources. The Mass General Health Center for Women's Mental Health, they have a virtual rounds every Wednesday. I think it's about 8 a.m. Hawaii time, and it's really great. Dr. Marlene Freeman and Dr. Lee Cohan, they're psychiatrists. They answer people's questions all throughout America on women's mental health. There's also a podcast, So Glad You Asked, that I've listened to by Dr. Ruta Nonax and Allie Hayes, a mother of four. They go over different topics covering perinatal mental health. Let's see, do I have this book here? I have this one book. I actually really like this book. It's called Good Moms Have Scary Thoughts. It's by Perrin Kleiman, Masters in Social Work. There's different illustrated pages here that women can look at that go over different, topics postpartum or even during pregnancy. This one particular page is of obsessive thoughts that women may have in the postpartum period. There's great illustrations and different like therapy tips, and then like things that you can journal and write in.